Thank you all for joining me today. My name is Amanda Avalos, and I'll be introducing you all to my scholarly project focused on educational interventions to improve the detection and early implementation of tumor lysis syndrome. The following committee members served as vital support to the dissemination of this initiative. Dr. Wunderlich, a chair member of Maryville University, provided ongoing support and direction from the start of the initiative to the end, accompanied by Christine Tarver, who served as the community member at the designated organization for which this DNP initiative took place. Additionally, Dr. Snell, a chair member of Maryville University, took the role as second reader to the finalization of this DNP initiative. My inquiry began with the concern for tumor lysis syndrome amongst individuals with cancer. For those of you who may not know, cancer continues to threaten the health of humankind due to high incidence rates and the aging population. In the U.S. alone, nearly a 50% increase in new cancer cases is projected to occur by 2050. Today, cancer is targeted with several treatment modalities, the most prevalently used adjuvant treatment being anti-neoplastic therapy. While treatment efficacy and effects from treatment modalities have improved, tumor lysis syndrome remains the leading life-threatening oncologic emergency in adults and pediatric patients with hematologic cancer. Tumor lysis syndrome more commonly presents in patients with acute leukemia, high-grade lymphomas with high tumor burden, bulky solid tumors, and high sensitivity to treatment. Tumor lysis syndrome is associated with life-threatening conditions such as hyperkalemia, hyperphosphatemia, hyperuricemia, hypocalcemia, and even death if not detected and treated early. The ramifications of electrolyte and metabolite imbalances can potentially cause fatal complications such as acute renal injury, arrhythmia, seizures, and neuromuscular instability. In the outpatient setting, the effects of care are not always known, seeing that patients are typically discharged shortly after treatment. In tumor lysis syndrome, failure to properly educate patients on potential adverse effects, when to seek medical care, and the significance of future follow-up appointments can result in life-threatening occurrences. Evidence-based clinical practice guidelines are developed to assist healthcare professionals with professional practice decisions on how best to prevent, monitor, and manage the treatment of individuals at risk for tumor lysis to optimize patient care outcomes. However, several barriers stand in the way of successful and consistent clinical practice guideline integration among healthcare professionals. Therefore, the purpose of this project was to determine if an educational intervention will promote consistent utilization of current practice guidelines by nursing staff, to improve the detection and early implementation of interventions to treat tumor lysis post as compared to pre-educational intervention. The project aims to increase the number of nursing staff adherence to standard of practice guidelines for tumor lysis, and secondary aims include improving the detection of tumor lysis, improving early implementation of interventions to treat tumor lysis, increasing nurse-to-patient education on tumor lysis effects, and improve patient outcomes. The literature review consisted of 10 articles which were grouped into the following 4 themes: barriers, facilitators, interventions, and patient outcomes. These themes provided the greatest support and guidance to support this initiative. The objective of the review was to find support and to be able to substantiate the need for educational intervention in improving adherence to clinical practice guidelines that will aid in early detection and implementation outcomes for patients receiving anti-neoplastic therapy. Overall, barriers to clinical practice guideline adherence was grouped into 4 categories, which included barriers related to guidelines, individual barriers, health professional human environment, and organizational and managerial environment. Barriers associated with guideline adherence included the complexity of guideline recommendations. Guidelines that are lengthy obtain conflicting guidelines, or possess a high number of conditional recommendations which provide a level of complexity that can be reflected as too cumbersome to follow. Individual barriers included a lack of awareness or knowledge of existing guidelines, a lack of trust in guideline development, and personal attitude towards practice guidelines. Health professional and organizational environmental barriers to guideline adherence include lack of training, limitation of available resources or presence of specialists, and time constraints due to clinical responsibilities. Factors that facilitate guideline adherence include practical use of guidelines, clinical competence via training and education, ease of access to guidelines, and team based cooperation. Creating a culture that promotes clinical competence supports the development of a cultured team approach towards cohesion between practice and clinical expertise. Furthermore, active participation in the development, implementation, and maintenance of guidelines heighten the significance and compliance with standardized practice. Interventional strategies to adherence focus on adding value to patient outcomes without increasing the burden of healthcare provider responsibilities. This strategy consisted of five-phase approach to guideline deployment that include nursing participation in development, assessment of readiness for deployment, and piloting the select sites before complete dissemination to all applicable sites. Alternate intervention strategies focused on improving ease of access to guidelines and training relative to optimizing cohesive use between healthcare professionals. When it comes to patient outcomes, clinical practice guidelines offer a means of providing patient care quality, reducing practice variation, and promoting efficient use of healthcare resources. Adherence to practice guidelines is associated with reduced deaths, medical emergencies, and overall improved patient outcomes. Furthermore, clinical practice guidelines standardize patient care, improve provider performance, improve disease outcomes, and increase survival. Significant changes in guideline adherence improve cost effectiveness, advance assessments of patients and other quality of care measures, and overall quality of care grounded on evidence-based standards of practice. Nursing theory guided practice allows nurses to hone in on their nursing practice and provides a foundation for professional practice, improving the quality of nursing care. I chose to use Cotter's change management model, which represents the implementation of this DNP initiative, focusing on compliance and adherence to tumor lysis clinical practice guidelines among nursing staff. The model focuses on enhancing awareness and practical change through leadership and focuses on the 8 variables you see in front of you to warrant lasting change. Creating a sense of urgency builds momentum towards the initiative and inspires leaders to act passionately and purposefully toward change. Creating a sense of urgency encompassed showcasing data to support the need for the change. Support from the organization and managerial leaders was vital in building momentum towards moving the initiative forward and believing in the vitality of the initiative's value. The guiding coalition is grounded on volunteers who guide, coordinate, and communicate the initiative. The team must be motivated, qualified, and possess the necessary skills to lead the change initiative. Instilling department managers and supervisors, organizational mentors, educational leaders, and university chair personnel assisted with formulating suitable stakeholders interested in leading change. At the stage of forming a strategic vision, clear objectives are formulated to differentiate the vision from the future and current practice. In this stage, the aim is precise and the strategic goals can be easily outlined. This initiative's strategic vision aligned with the organization's core values of excellence, collaboration, and service with a sense of urgency. The next step in the process highlights inclusivity, which incorporates nurses to be part of the decision-making, problem-solving, or implementation process. Engagement by the user imparts meaningful change that supplies purpose and increases the success of implementation adherence. The following variable focuses on removing obstacles that impact progress. This project enabled removing barriers through disseminating an educational process and designating change agents to neutralize resistance. The initiative provided awareness to quick link tools and resources that decrease the time to access clinical practice guidelines. Generating short-term wins is described as a foundational building block of results. The dissemination of wins provides a sense of accomplishment and maintains momentum and encourages end users to continue supporting the initiative's efforts. The initiative aimed to improve adherence, so instilling short-term wins provided the encouragement needed to maintain the practice outlined by clinical practice guidelines. Sustaining acceleration is to promote long-term wins. So to achieve this, each evaluation point required identifiable successes and failures to be addressed and encourage momentum towards sustained success. In the variable of institute change, it is represented by replacing old habits as expressed by reinforcement of practices in the mindset and work ethic across all roles of the organization. Sustained change is expressed as a new culture of practice and is reflected as the organizational's norms. Cotter's model allowed for barriers, knowledge gaps, and strategies for education dissemination to be addressed. Using Cotter's change management model, adherence to clinical practice guidelines became an organizational practice change that will integrate sustainability through new cultural norms. This initiative was conducted at an outpatient oncology infusion clinic located in the western region of the U.S. This project is a quality improvement initiative with a quantitative exploratory design. The participants for the scholarly project included clinical trial infusion research nurses, and adult leukemic patients. Data was extracted from electronic medical records of leukemia patients 18 years and older who had been approved for clinical trial treatment with antineoplastic therapy and required monitoring for tumor lysis based on sponsor protocol in the targeted clinical trial infusion clinic. Prior to this initiative, the use of evidence-based practice guidelines for tumor lysis detection and treatment were not consistently utilized. To address this issue, the following strategies were implemented. The first was an educational intervention, which was presented to clinical research infusion RNs and support personnel. The educational seminar included current practice guidelines for the care of patients with leukemia receiving antineoplastic therapy and at risk for tumor lysis. The next strategy was providing education on how to use quick link references embedded in the electronic medical records and facility intranet. And lastly, the facility clinical practice guideline for TLS detection and treatment was posted in the nurses station for quick reference. Data collected from the electronic medical records were imported into an Excel data collection sheet, which included lab values of TLS, if medical doctors were notified, and if medical doctors needed to be notified. The same data collection sheet in the pre and post intervention period was utilized to analyze a total of 200 participants. I heavily relied on the prevention and treatment of tumor lysis decision algorithm tool when creating the data collection sheet. Primarily, the tool helped establish how I would quantify adherence to the guidelines. In the study, descriptive statistics were employed to assess the demographic profile of both the pre- and post-educational intervention groups. The sample population consists of 31% female participants, which accounted for 62 females, and 68% male participants, which accounted for 136 males. In Figure 1, you will see the distribution of that data in the pre- and post-educational intervention groups. The racial ethnic composition of the sample was as followed. So there were a total of 2 African Americans, which accounted for 0.01%, 146 Caucasians, which accounted for 73%, 48 Hispanics, which accounted for 24%, and 4 of unknown ethnic background, which accounted for 0.02%, which is reflected in Figure 2 between both groups. This information serves as an important foundation for further analysis and interpretation of the research findings. Collected data to determine if there was a statistically significant difference between pre- and post-educational intervention for the detection and treatment of tumor lysis syndrome. A statistical test called the Z-test for the difference of 2 proportions with a significant level of 0.05 was used. The Z-test for the difference of 2 proportions is a way to compare the proportion or percentage of 2 independent populations. In this case, I was looking at the proportion of people who properly followed clinical practice guidelines for TLS before the educational intervention compared to the proportion after the intervention. Since the data was collected both before and after the intervention, the pre-intervention and post-intervention groups are independent of each other. Therefore, I used the 2 proportion Z-test to determine if the post-educational intervention resulted in significantly higher adherence to the clinical practice guidelines for TLS compared to the pre-education intervention group. The Z-test, which compares 2 proportions, showed that the educational intervention given to registered nurses was effective in managing tumor lysis syndrome in leukemic patients undergoing anti-cancer therapy, especially when compared to situations where the nurses did not receive this educational training. The reported significance level was 0.0132. Therefore, there was a statistically significant decrease in the number of required providers notified by registered nurses before and after the educational intervention. The control group, which included participants who followed traditional practices, showed more variability in how well they adhered to the clinical practice guidelines for tumor lysis, with the standard deviation of zero point 0.8, which you can see in Figure 3. In contrast, the interventional group, which included participants after the educational intervention on the guidelines, showed less variability in their adherence to TLS practice, with a standard deviation of 0.23, as seen in Figure 4. The resulted decrease in the standard deviation and variability in the post-test score was the desired goal of the study. Despite analysis of a sample population of 100 participants from each pre- and post-educational intervention group, less than half of the sample required intervention for tumor lysis management. The size of the study included pre-test and post-test scores from 18 participants during the designated time frame, providing a poor sample size. In this particular study, the sample size was quite small, with 13 participants in the pre-intervention group and 5 in the post-intervention group requiring medical provider intervention. This sample size likely did not capture the full variability that exists in the overall population, leading to unreliable conclusions. A larger, more representative sample would be needed to draw accurate findings. Certain limitations were evident. First, a small sample size increases the chance of a type 1 error, which means the analysis may not be strong enough and cannot safely fit multiple regression models. Second, the data was collected retrospectively, which means there is a high risk of selection or confounding biases and subjectivity. It is important to note that laboratory markers may have been measured at different times during the development of TLS according to the different sponsor protocol guidelines. The dosing and timing of administering rate-lowering agents and other supportive treatments were also inconsistent across the various sponsor protocol guidelines. Lastly, because there were no control groups, the data did not allow for an investigation into the predisposing factors of TLS other than the narrative reporting of the triggering factors suggested by the clinical trial sponsor. More extensive studies are needed to better determine the parameters for comparing different rate-lowering regimens regarding effectiveness and safety to identify currently less known triggering factors or predictors of worse outcomes. However, conducting such studies is challenging due to the rarity of tumor lysis in leukemic patients being treated in outpatient settings, especially when the analysis is limited to cases treated under sponsor protocol. Since this is not a longitudinal study design, individuals may temporarily change their behavior because they know they are being observed as part of a study. This is common among participants who are aware they are part of a study compared to those who are not. The awareness of being observed and the specific variable being measured can affect the true results of a study. However, the more significant limitation remains the inability to apply the findings to a broader population in most studies. There were some barriers and facilitators that related to the impact of this initiative. Some challenges relate to ongoing education and planned educational seminars, such as limited time and irregular staffing patterns. Although the educational seminar was held during staff meetings, the time was shared with other meeting topics. Additionally, some staff members who attended these meetings were working and were called away at any moment to help with patient care. Scheduling can be unpredictable, and planned educational activities or time set aside for education can change or be canceled suddenly. It was hard to educate a large number of staff members all at once. Another important point is the unpredictable nature of staff taking leave during this time. Additionally, information learned during the educational seminar may be hard to retain due to the heavy load of education the unit already has. The final barrier is the lack of responsibility among providers. During the study, the unit was still in the process of finalizing its after-hours provider notification chain of command algorithm, which is a critical component of timely patient care. This delay in finalizing the process may have a profound impact on the timely notification of tumor lysis lab results and provider notifications, underscoring the gravity of the situation. Facilitators include having a hospital-based nurse educator help to answer questions or concerns that needed more clarification on tumor lysis protocol. Together with the employees and the educator, the researcher identified learning needs and used strategies to address them. This created an ongoing learning process that included daily reminders during huddles about resources related to tumor lysis prevention and management according to clinical practice guidelines. Other supporters included management, unit educators, and unit-based practice council. The collaboration among these groups helped reinforce tumor lysis clinical practice guidelines and ensured consistent and informed education instruction for nursing staff. There is still a lot of variation in the evidence about how effective different strategies are for implementing guidelines. Future studies should look into how new cancer treatments influence the occurrence, risk level, and presentation of tumor lysis. By doing this, clinical practice guidelines can be updated to reflect the latest cancer treatment methods and advancements seen in clinical trials. Including considerations for implementation in the guidelines can significantly affect how easy they are to put into practice and should be explored further. Additionally, research on various methods should be further studied to reduce differences in practice, eliminate barriers to following guidelines, improve awareness and familiarity with the guidelines, and overcome resistance to changing old practices. Overall, there is no structured evaluation of how clinical guidelines are utilized and implemented into practice. Generating application reports that measure use and adherence to select guidelines through routine data analysis would help improve adherence and identify gaps in educational support. It is also essential to determine whether a solitary educational approach or a multifaceted intervention can enhance healthcare professionals' adherence to guidelines and help achieve treatment goals. More research should be conducted across multiple outpatient clinics over a long evaluation period to better assess validity and strengthen confidence in the results. In conclusion, the integration of clinical practice guidelines is influenced by the development, quality, and communication of material. Education for healthcare professionals and printed materials are the most common strategies for translating guidelines into practice. However, practices vary widely, and gaps in clinical practice guideline application and sustainability are evident. Consistent and comprehensive guidelines must be updated to keep pace with evolving cancer treatment methods and advancements. Therefore, staying well informed on the latest evidence-based clinical practice guidelines is essential, as following these guidelines can significantly affect patient outcomes. While it is difficult to confidently explain the observed differences in effectiveness due to the small sample size of this initiative, it suggests that higher adherence to clinical practice guidelines is linked to interactive and didactic education. This concludes my presentation. I'd like to take this time to answer any questions you may have. The QR code provides a list of my references. Thank you all for your time and have a great day.